All right, let's dive in. We've all been there, right? Staring at this huge pile of notes. Maybe for an exam, maybe just trying to keep up with, patient care stuff. It's all important, but how do you pull out the really critical bits?
Yeah.
The surprising stuff?
Exactly. You've got this dense material, which is great. It's the foundation. But finding those key aha moments, the things that actually make a difference in practice, they can get buried.
Totally. So that's what we're doing today. We're taking this deep dive using a really comprehensive set of study notes. Covers a ton. Fluids, emergencies, wounds, bones, you name it.
And we're going to walk through it with you, pull out those essential nuggets, the stuff that really clarifies things, basically give you a shortcut to feeling confident about what's in here and why it matters for actual patient care.
Think of it as your guided tour through the notes. Ready?
Let's do it.
Okay, first up, fluids, IV basics. Seems simple, but these notes break it down really well by tonicity, which, tells you where the fluid actually goes.
Right. So you've got your hypertonic solutions like half normal saline, third normal saline, D2.5W. They're less concentrated than your blood.
So the fluid moves out.
Into the cells, yeah. Into the tissues. Good for cellular dehydration.
Then isotonic. That's the middle ground.
Yeah.
Like normal saline, LR, D5W. Same concentration.
Exactly. And these mostly stay put, right, in the blood vessels. Great for just boosting volume if someone's pressure is low, maybe they're dehydrated or lost blood.
And the last type.
Hypertonic.
Yeah, more concentrated stuff, D5NS, D10W, even stronger like 3% or 5% saline.
And because they're concentrated, they pull fluid
out of the cells and tissues back into the blood vessels. So useful if you need to shrink swollen tissues like brain swelling, increased intracranial pressure.
Okay, that makes logical sense. Concentration drives the movement.
Yeah.
But the notes have some big warnings too, right? Like D5W, it's listed isotonic, but there's a catch.
Yes. This is a perfect example. The notes flag this really clearly. D5W starts isotonic, but your body burns through that dextrose, that sugar, super fast. What's left? Basically water. So it acts like a hypotonic solution.
Exactly. And the big warning, especially highlighted for kids, is the risk of hyponatremia, low sodium, and cellular swelling. That's a critical piece of info you absolutely need to know. A real don't miss this point from the notes.
Wow, okay. Definitely noted. What about albumin?
Albumin's different. It's a protein, a colloid. Its main job is maintaining oncotic pressure, sort of a pulling force, keeping fluid in the blood vessels. Slower effect than crystalloids like saline, but lasts longer.
And D50, dextrose 50%.
Yeah.
Sounds potent.
It is. Very specific use. Severe hypoglycemia, really low blood sugar. It's a fast shot of concentrated glucose right into the vein.
Got it. So you pick the fluid. Now you need the IV access. The notes mention sizes.
Yeah, practical stuff. Older patients, maybe more fragile veins. You might go smaller, like a 22 or 24 gauge. Standard fluids, maybe 20, 22.
But for blood?
Blood needs a bigger pipe. It's thicker. Notes say 14 to 18 gauge usually, so it flows well and you don't, damage the red cells.
And choosing the site, getting it in, watching it. That's all on the nurse. And things can go wrong right at the site, can't they?
Oh, absolutely. The notes list the common local problems. Like infiltration fluid leaks into the tissue, feels cool, looks swollen, you got to stop it, find a new spot.
And extravasation.
Similar leak, but with a medication that irritates the tissue, can cause redness, pain, even tissue death, necrosis. Much more serious.
Phlebitis is just the vein getting inflamed.
Right. And thrombophlebitis is inflammation plus a clot. Then there's hematoma, just a bruise, basically. Blood leaks out under the skin. Maybe you went through both sides of the vein, something like that.
And these aren't just local issues. Systemic problems can happen too. Fluid overload.
Yeah, too much volume. You'll see edema, high blood pressure, fast heart rate, maybe crackles in the lungs, JVD, those neck veins popping out.
Sounds bad. And infection.
And septicemia.
Also really serious. The notes give that simple reminder. Scrub the hub. Just scrubbing that IV port for 10, 15 seconds before you access it makes a huge difference in preventing infection.
Simple, but crucial. Okay, speaking of crucial, blood transfusions. The notes lay out a very strict process here.
They absolutely do. It's all about safety checks. Starts with the type and screen or cross-match. Get baseline vitals before you even call the blood bank. Educate the patient. Get that signed consent witnessed, then verify the order, get your supplies ready.
And the big bold rule from the notes.
Only normal saline. Nothing else is compatible. Never, ever mix medications with blood in the same line.
Wow. Non-negotiable. And the timing.
Super strict. Once the blood leaves the bank, you have 30 minutes to start it. And the whole thing has to be done within 4 hours. Prevents bacterial growth, keeps the cells viable.
How do you monitor during?
Start slow, like really slow, 5 milliliters a minute maybe. Stay with the patient for those first 15 minutes. Okay, you can speed it up, check vitals at 15 minutes, then hourly usually, and watch for delayed reactions afterwards too.
The notes mention PRBCs specifically.
Packed red blood cells, yeah, most common type. Used for anemia, basically to boost oxygen carrying capacity.
And if anything looks like a reaction, SOP, immediately. Stop the infusion, then assess your patient, call the provider, and remember that detail about the tubing. If there's a reaction, save the bag and tubing for the lab. Otherwise, it's biohazard.
Okay. The notes break down the different reaction types too. Febrile.
Febrile non-hemolytic. Pretty common, sometimes in people with lots of transfusions or births. Chills, then a fever. Usually managed okay.
Acute hemolytic sounds worse. The notes mention back pain.
Yes, that's a key sign. It points to kidney injury because the incompatible cells are breaking down. You also see fever, chills, shortness of breath, maybe blood in the urine. Very serious.
Allergic reactions.
It can be mild hives, itching, or severe anaphylaxis. Treat with antihistamines, maybe epinephrine if it's bad.
TACO. Transfusion-associated circulatory overload.
Yep, just like fluid overload, too much volume too fast. Shortness of breath, high BP, tachycardia, JVD.
Bacterial contamination.
Emergency. Sudden high or low blood pressure triggers those really intense chills, possible collapse. Treat like sepsis. Transfusion-related acute lung injury, usually within 6 hours. Non-productive cough, trouble breathing.
And delayed hemolytic.
Happens days, weeks later. Might be subtle fever, just feeling unwell. Can be missed sometimes.
Man, the nurse's role here is just huge.
Yeah.
Verifying, identifying, checking compatibility, monitoring, reacting. So much responsibility.
It really is. Okay, let's shift from blood inside to healing outside. Wound care. The notes talk about healing by intention.
Right. First intention.
Clean surgical cut, edges brought together neatly, stitched or glued. Heals fast, minimal scar.
Second intention.
Wounds left open, heals from the bottom up, fills in with tissue, like a pressure ulcer or a big burn. Slower, more scarring.
And third intention.
Kind of a mix. Maybe the wound was dirty, so it's cleaned, left open to start healing from the bottom, then closed surgically later. The notes also describe drainage, cereals.
Clear, watery, purulent.
Thick, yellow, green, brown, means infection usually. Sanguineous.
Bloody. And serosanguinous.
Pinkish, mix of bloody and watery.
And staging wounds, especially pressure injuries. Stage 1.
Intact skin, but it's red, and if you press it, it stays red. Non-blanchable erythema. Stage 2 is like a blister or a shallow crater. Partial thickness skin loss, you can see the dermis.
Stage 3, you see fat.
Full thickness skin loss, subcutaneous fat is visible, but you don't see muscle, bone, or tendon.
Stage 4, you do see those.
Yep. Full thickness, exposed bone, tendon, or muscle.
And unstageable.
Can't see the bottom. Covered by slough, that yellowish, stringy stuff, or eschar, the hard black or brown dead tissue. What you want to see in a healing wound is granulation tissue.
That healthy pink stuff.
Exactly. Fleshy, pink, or red, moist. Means it's rebuilding. You gotta protect that.
Sometimes wounds need drains.
Penrose.
That's an open drain. Just a tube lets fluid seep out passively onto a dressing and close drains. JP or Hemovac.
Right. Jackson Pratt or Hemovac, they use suction a bulb or container you squeeze to pull fluid out.
Okay.
Lower infection risk than open drains.
Okay, 2 scary wound complications the notes highlight. Dehiscence.
The wound splits open, maybe you see some fat or muscle layers.
Right. And eviscerate. Even worse. Wound opens and organs are actually sticking out.
And the immediate first aid for both, according to the notes.
Cover it. Sterile dressing soaked in normal saline immediately, especially for visceration. Cover it. Call a surgeon. It's an emergency.
Good. The notes also lay out the healing phases. Inflammatory first.
Yeah, first few days, stopping bleeding, cleaning up debris with macrophages, then proliferative.
Day 3 or 4, up to about 3 weeks. Building new tissue collagen, granulation tissue fills the gap. And finally, maturation.
From 3 weeks onwards, could be a year or 2. Scar tissue remodels, get stronger, can form keloids here sometime.
And a little practical nugget. The surgeon usually does that very first dressing change after surgery.
Good to know. Okay,
Yeah.
Moving from skin to structure. Bones, fractures, emergency management.
Immobilize it first, splint it where it lies, stop any bleeding with sterile pressure, check the site, check the pulse downstream, assess those 5 Ps, and the big, don't.
Don't try to straighten it out or push it back in.
Exactly. Leave reduction to the pros. Complications can be nasty, though. Notes list compartment syndrome, fat embolism.
Shock, DIC, blood clots. Let's focus on compartment syndrome again. The notes really stress this one.
Because it's limb-threatening. Too much pressure inside the muscle compartment cuts off blood flow. The 5 Ps are key signs: pain, pallor, pulselessness, paresthesia, that's numbness or tingling, and paralysis.
But the notes mention a specific kind of pain.
Yeah, pain that's way out of proportion, uncontrollable with normal meds, feels like intense tightness, or hurts like crazy when you passively stretch the muscles. It's like a huge red flag.
And the number one intervention, or rather non-intervention?
Do not elevate the limb. It feels counterintuitive, like you should raise a swollen limb, but for compartment syndrome, it makes it worse by lowering blood flow to the area. Assess, don't elevate, get ready for a fasciotomy surgery to cut open the compartment and relieve pressure.
Wow, okay. Fat embolism from a fracture.
Mm-hmm.
The unique sign.
Petechia, those little pinpoint red spots, often on the chest or in the eyes. If you see that with a long bone fracture, think fat embolism. Also watch for sudden breathing problems, rapid heart rate. Need respiratory support.
Sprains and strains are more common, less severe. Ligament versus muscle tendon. Notes say IC.
Yep. Rest, ice, compression, elevation, standard stuff.
And that neurovascular assessment, the 5 Ps, again, is vital for any musculoskeletal injury. Right? How often?
Notes say check every hour for the first 24 hours, then every 4 hours after that. Report changes immediately. It's your early warning system.
Hip fractures or dislocations need to keep the hip aligned.
Yeah, often use an abduction pillow between the legs to prevent crossing them and keep the hip stable.
Oh.
And, you guessed it, assess the 5 Ps.
Cast care. They dry pretty fast now.
Fiberglass does, yeah. Plaster takes longer. Elevate the limb, keep checking those 5 Ps. Oh, and reassure patients the cast saw vibrates. It doesn't spin like a regular saw, so it won't cut their skin.
Traction. Big rule.
Never interrupt it. Don't remove the weights unless ordered. Make sure they hang freely, not resting on the bed or floor.
Box traction, that's skin traction.
Right. Keep the patient straight in bed. Watch for skin breakdown, especially heels, sacrum.
Skeletal traction has pins in the bone.
Yep. Pin site care is important. Notes mention leaving crusty drainage alone. It can be protective. Check the sites and make sure the pin caps are on. If a cap is missing, call the surgeon.
All right, shifting to chronic bone issues, osteoporosis, brittle bones.
Risk factors are numerous in the notes. Long-term PPIs or steroids, alcohol, family history, being postmenopausal, low calcium vitamin D.
Also mentions kids with certain conditions, some athletes, pregnant women. Prevention is key. Calcium, vitamin D, weight-bearing exercise, avoid smoking, limit alcohol and caffeine.
Diagnosis. DXA scan is best.
Gold standard, yeah.
Yeah.
DXA measures density accurately. X-rays show fractures but aren't great for early detection.
Medications. Calcitonin nasal spray.
Alternate nostrils. And the biphosphonates Fosamax, Actonel Boniva, really specific instructions here. Right. Empty stomach, big glass of water, stay sitting upright for 30 minutes afterwards. To avoid esophageal irritation, often taken just once a week. Report chest pain. Need calcium too, usually.
Osteomyelitis bone infection. Notes link it often to open wounds, especially in diabetics.
Yeah. Signs are pain, swelling, tenderness, constant pulsing pain, worse with movement, and that's specific flag. A diabetic foot ulcer bigger than 2 centimeters is highly suspicious. Needs long-term antibiotics.
Amputations. Closed versus open guillotine.
Closed is shaped for a prosthesis. Open might be for bad infection, left open initially. Stump care post-op involves compression wrapping, shaping the stump, controlling swelling. Range of motion exercises are key too. Prevent contractures.
And preventing blood clots, venous thrombosis after surgery or injury is huge.
Dorsiflexion, pumping the feet. SCDs, those leg squeezers, blood thinners like heparin or Lovenox, and getting up and moving early.
Early ambulation is so important for so many things, especially preventing clots.
Okay, let's touch on some key medications mentioned. Corticosteroids, prednisone.
Big impact. Raises blood sugar, take with food, causes weight gain, swelling, suppresses the immune system. And a critical warning. Never stop abruptly. Always taper off.
IV med onset.
Fast, like seconds to minutes. The notes give that general guide for IV push, maybe 1 ml per minute. But caution, some meds need to be pushed slower. Morphine, Zofran are examples given.
Dermatitis treatments.
Antihistamines, watch for drowsiness. Topical steroids, careful with long-term use, risk of skin thinning or withdrawal issues. And meds for mobility pain, OTC stuff.
Acetaminophen pain, no anti-inflammatory. Aspirin pain, inflammation, fever reducer, but interacts with other anticoagulants. NSAIDs like ibuprofen pain, inflammation, but watch the GI side effects.
Prescription muscle relaxers, Baclofen, Xanaflex?
Help with spasms, stiffness, that can cause drowsiness, respiratory depression, and a big warning. Don't mix with opioids. Really increases the risk of stop breathing.
Okay, the whole surgical timeline. Perioperative care, 3 phases.
Preoperative from decision to the OR door. Intraoperative in the OR until PACU. Postoperative PACU through recovery.
Nurse's role in consent is key. What exactly is it?
Verify the surgeon explained everything and got the signature. You can clarify what was said, but if the patient still has questions or is unsure, you have to call the surgeon back and consent before any sedating meds are given.
Makes sense. Elements of valid consent.
Freely given, patient is competent, 18 plus or emancipated. Physician explained it all, witnessed by staff. Notes also cover incompetence if someone can't consent due to cognitive issues, intoxication, etc. Nurse advocates ensure a proper surrogate is involved.
The notes also list things LPNs typically can't give via IV.
Yeah, specific high-risk things. Clot busters, blood products, IV sedation anesthesia, IV insulin, chemo. And they can't access implanted ports or central lines directly. Clear scope of praxis stuff.
The circulating nurse role sounds vital in the OR.
Totally. They're the patient's main advocate during surgery. Manage the room, protect the patient, monitor the team, check equipment, constantly assess the patient from outside the sterile field.
Preventing complications after surgery. Movement is key.
Absolutely. Turning, leg exercises, early walking prevents DVT and PE.
And for the lungs?
Deep breathing, coughing, and using that incentive spirometer prevents pneumonia. How to use the spirometer again.
Big, slow breath in, like sucking on a straw. Get the ball or piston up to the goal mark. Hold a sec, then breathe out slowly. Aim for about 10 times an hour while awake. Common pre-op labs mentioned.
Clotting studies, PT-PT-TINR, CBC, electrolytes like sodium, potassium, maybe blood gases, definitely a pregnancy test if applicable, protein, glucose, ECG, chest x-ray, depends on the surgery and patient. Post-op assessment frequency, right after surgery.
Airway and breathing, check every 15 minutes initially. Vitals, cardiovascular usually every 4 hours, but more often if needed. Hypothermia risk.
Yeah, cold OR, cold fluids, body exposure, less muscle activity. Warm them up slowly with blankets.
And if a patient vomits while still groggy from anesthesia,
turn their head to the side immediately. Prevent aspiration. Lower the head of the bed. Suction if needed.
Okay, couple of final concepts pulled from the notes. Phantom limb pain.
Real pain after amputation. Described as coldness, heaviness, cramping, shooting, burning. Assess it like any other pain. 0-10 scale. Becky, again, sign of fat embolism with fracture.
DVT signs.
Usually one calf. Tenderness, warmth, redness, swelling. Measure both calves to compare. Report it.
Normal plasma osmolality range.
Notes give 270-300 millosm Coega. Basic measure of blood concentration, hydration.
Assessing darker skin tones.
Look at mucous membranes inside the mouth, eyes, palms, soles of feet, nail beds. Compare affected side to unaffected side. Redness or pallor can be harder to see otherwise. And third, spacing.
Fluid shifts out of the blood vessels into places it shouldn't be, like the belly or swollen tissues, making it useless for hydration.
Yeah, fluid balance is more complex than just ins and outs. It's about location, too.
Wow. Okay. We really covered a lot there, digging into those notes.
Yeah, from fluids and transfusions to wounds, bones, meds, surgery, all those critical details. And seeing how it all connects, right? Like fluid balance impacting transfusions or why checking pulses is vital with a broken bone. It brings those specific rules and protocols to life.
It moves beyond just memorizing facts to understanding the why for patient safety.
So we've looked at the what and how from these notes, but think about this. How does knowing these very specific rules, like the 5-piece check every hour, the 30-minute blood window, not elevating for compartment syndrome, how does that change the way you approach patient care? Beyond just following the rule.
It builds that constant vigilance, right? That detailed mindset, because you understand the potential consequences.
Exactly. So thinking about everything we pulled out, what's the one piece of knowledge from this dive that really stands out to you now? What feels like the most impactful rule or surprising fact we highlighted today?